Coming to management of pulmonary embolism. So pulmonary embolism can be classified into, based on the presentation, massive pulmonary embolism, submassive pulmonary embolism, massive pulmonary embolism, submassive pulmonary embolism, minimal pulmonary embolism. Massive pulmonary embolism in the sense patient will present with shock and there will be right ventricular dysfunction. Whereas in submassive pulmonary embolism, there will be normal BP with some amount of right ventricular dysfunction. In minimal, the BP will be normal and also normal RV function. BP will be normal and also normal RV function. Now, because massive pulmonary embolism is associated with shock. Shock is a medical emergency. So immediately you should stabilize the patient. I give him IV normal saline 500 ml to improve his BP. Along with that, vasopressors. This is also given to improve his BP. Then we start anticoagulation. Now what is the advantage of anticoagulation? So these anticoagulants will decrease the progression of thrombus and also the chances of rethrombosis. It will make sure the thrombus is not extending and the chances of rethrombosis it will prevent. When they ask you what is the definitive treatment, this patient is with shock, and there is a big thrombus occluding pulmonary circulation. Definitive treatment is bringing the perfusion back to that vessel. That is reperfusion treatment in the form of breaking the thrombus. That is thrombolysis. If thrombolysis is not possible, next option will be surgical embolectomy. Now in submassive cases, we are going to start anticoagulation first. If patient improving with anticoagulation, that is sufficient. If patient develops hemodynamic compromise, in those conditions you should go for thrombolysis. Minimal means small thrombus, just anticoagulation will be sufficient. Students, you will be frequently confused between the management of massive pulmonary embolism and submassive pulmonary embolism. In massive pulmonary embolism, definitely in majority what should be done? The thrombus should be broken down, thrombolysis. Whereas in submassive pulmonary embolism, you start anticoagulation. If patient is improving with anticoagulation, it is sufficient. If he is not improving, done only thrombolysis. So in massive, definitely in majority. In submassive, you do it selectively in patients not improving with anticoagulation. Then what will be the drugs that we use for thrombolysis and what will be the drugs that we use for anticoagulation? Now drugs for thrombolysis, we give altiplase. It's not streptokinase generally, we give altiplase, recombinant tissue plasminogen activator. For anticoagulation, the traditional therapy is heparin bridged to warfarin. So heparin combined with warfarin. And the newer regimens we have heparin followed by dabigatran. Dabigatran is a direct thrombin inhibitor. or we can go for rivaroxaban, apixaban. These are factor 10A inhibitor. The conventional regimen is heparin bridged to warfarin, whereas the new regimen we can either give dabigatran, that is direct thrombin inhibitor, rivaroxaban, apixaban. Rivaroxaban, apixaban. These are factor 10A inhibitors. Now the problem with thrombolysis, because we are giving it through an IV route, it will not only go into the pulmonary circulation, it can go throughout the body. Now suppose patient is having some bleeding tendencies, some GI ulcer, so this can aggravate the bleeding and resulting in bleeding complication. So the main disadvantage with thrombolysis will be bleeding complications. Main disadvantage will be bleeding complications. Now to overcome these bleeding complications, there is a new method of thrombolysis. What is that? Now here I am directly going to put a catheter in the pulmonary circulation. Wherever there is thrombus, I am going to do intraclot infusion of thrombolytics. So this is a advanced method called as catheter directed therapy, because directly you are introducing the thrombolytic into the pulmonary circulation. The dose of the drug is less. It is a targeted thrombolysis, and because the dose is less, there are less chances of bleeding complications. Because the dose is less, there are less chances of bleeding complications also, students. This is regarding the catheter directed therapy, intraclot infusion of thrombolytics. Coming to the classical pattern ECG, S1, Q3, T3 pattern. You can notice deep S wave in lead 1, Q waves in lead 3, and inverted T waves in lead 3. Now is it most common pattern or most specific pattern? It is most specific pattern. Now why such changes happen in the ECG? You know that whenever there is a big thrombus, there will be change in morphology of your right heart. There can be right ventricular dilatation and also increased pressures in the right ventricle. All this can result in this S1, Q3, T3 pattern. S waves in lead 1, Q waves in lead 2, and inverted T waves in lead 3. Now let us see a case. There was a 75-year-old male with a history of colon cancer, admitted in ICU. He developed sudden onset dyspnea with chest pain and hemoptysis. His BP was 100/70, heart rate 110, respiratory rate 28, SpO2 88% on room air. There is no tenderness in the lower extremities. ABG shows type 1 respiratory failure. Chest X-ray is normal. They have given you lot of information. Which of the following test in order to confirm your diagnosis? Now what is the clinical scenario suggestive of, students? It is suggestive of a pulmonary embolism. For pulmonary embolism, how will you confirm the diagnosis? The single best answer should be CT pulmonary angiography. Now this was a real case that I have seen. I have suspected pulmonary embolism and I have done a CT pulmonary angiography. This was the picture. What do you see here? This is your pulmonary artery. Can you tell me why is your pulmonary artery very white? Because it is filled with contrast. Contrast makes the vessels white. In that area of white, if you see anything less white like this, what is this? This is thrombus in the pulmonary circulation. See here how beautifully this CT pulmonary angiography is localizing the thrombus in the pulmonary circulation within no time. That's why it is considered as investigation of choice. The next topic, pulmonary hypertension. What is the definition? Pulmonary hypertension is defined as mean pulmonary arterial pressure, mean pulmonary arterial pressure, also called as MPAP, also called as MPAP, more than 20 mmHg, or in terms of pulmonary vascular resistance, in terms of pulmonary vascular resistance, in terms of pulmonary vascular resistance, more than 3 Wood units. Just like for distance we have meters, kilometers, for resistance we have Wood units. Mean pulmonary arterial pressure more than 20 mmHg, or pulmonary vascular resistance more than 3 Wood units is the standard definition. Now some one-liners. What is the initial method of assessment? Your answer should be echocardiography. Echocardiography is considered as initial method of assessment. What is the most accurate method? For measuring a pressure in the vessel, most accurate is always putting a catheter. Pulmonary artery catheterization is the most accurate method for measurement of pressure. Whenever there is some issue in the pulmonary circulation, gas exchange will not happen properly. This results in a most common symptom called as shortness of breath. Echocardiography is the initial method of assessment. Pulmonary artery catheterization is the most accurate method, and most common symptom will be shortness of breath, students. Most common symptom will be shortness of breath. Now for pulmonary hypertension, WHO has given a classification. So write down WHO classification of pulmonary hypertension. This classification is based on mechanism. Based on mechanism, pulmonary hypertension is classified into 5 groups. Let us see the important groups, students. Let us see important groups. We have group 1. Group 1 is due to direct involvement of pulmonary artery. Group 1 happens because of direct involvement of pulmonary artery. It can be either due to a genetic cause. It can be either due to genetic cause. It can be due to connective tissue disorder. CTD means connective tissue disorder. Or it can be due to some drugs or toxins. It can be due to some drugs or toxins. Genetic causes, mostly it is due to mutation. It is due to mutation in a gene called as BMPR2 gene. Because of mutation in this gene, there will be increased smooth muscle proliferation. There will be increased smooth muscle proliferation within vessel. There will be increased smooth muscle proliferation within vessel. Because excess smooth muscle is getting proliferated in the vessel can get narrowed. That will result in increased pulmonary arterial pressures. And this type of pulmonary arterial hypertension is generally seen more in young females. It is seen in more in young females. Then coming to connective tissue disorders. Connective tissue disorders such as scleroderma, rheumatoid arthritis and SLE, as a part of systemic involvement, they can directly involve the pulmonary artery, resulting in pulmonary hypertension. What will be the most common CTD responsible? Your answer should be scleroderma. Most common CTD responsible is scleroderma. Other connective tissue disorders such as rheumatoid arthritis, SLE can also cause. but most common CTD will be scleroderma. Drugs or toxins. Drugs such as fenfluramine. Toxins such as toxic rapeseed oil. This drug and this toxin can directly involve the pulmonary circulation. It can directly involve the pulmonary circulation and it can result in pulmonary hypertension. This is group 1. Now coming to group 2 pulmonary hypertension. Group 2. This group 2 is due to left heart disease. This is due to left heart disease. We know that left heart disease can cause pulmonary hypertension. What is the mechanism? I have discussed. Because of left heart disease, there will be increased back pressure. Because of this increased back pressure, there will be increased left atrial pressure that will result in, because of back pressure, because of some left heart disease, there will be increased left atrial pressure that will result in increased pulmonary venous pressure. Increased pulmonary venous pressure that can result in increased pulmonary capillary pressure. Increased pulmonary capillary pressure that can result in increased pulmonary arterial pressure. Increased pulmonary arterial pressure. And point to remember here is, students, this is due to left heart disease. Because there is pulmonary hypertension, there will be elevated MPAP. Along with that, because it is due to left heart disease, there is increased left atrial pressure. What else will be elevated? PCWP will also be elevated. There will be increased MPAP and increased PCWP. There will be increased MPAP and increased PCWP. And moreover, this group 2 is considered as most common group responsible for pulmonary hypertension. Now we know that WHO has given a classification based on the mechanism. Out of all these groups, if they ask you what is the most common group, what is the most common group, your answer should be group 2. The group associated with left heart disease, your answer should be group 2. The group in which both MPAP and PCWP are both elevated, again your answer should be group 2. So many important points regarding group 2. Most common group associated with left heart disease, a group where both MPAP and PCWP are elevated. Coming to group 3 pulmonary hypertension. Group 3. Group 3 pulmonary hypertension. This is due to primary respiratory cause. Primary respiratory cause such as COPD, ILD, bronchiectasis, COPD, ILD, bronchiectasis, obstructive sleep apnea, obstructive sleep apnea. So how will a primary respiratory cause be responsible for pulmonary hypertension? I told you, chronic respiratory diseases, long-standing hypoxemia. Hypoxemia will cause persisting pulmonary vasoconstriction. There can be pulmonary vasoconstriction. This pulmonary vasoconstriction can be responsible for pulmonary hypertension. It can be responsible for pulmonary hypertension. Then coming to group 4. So group 4, this is due to chronic thromboembolic events. This is due to chronic thromboembolic events. in pulmonary circulation. Group 4, it is due to chronic thromboembolic event in pulmonary circulation. Then group 5, this is considered as miscellaneous group or group with unclear mechanism. We don't know why exactly it is happening. What are the diseases? Rare diseases such as sarcoidosis, sickle cell disease, and rare diseases such as Langerhans histiocytosis, lymphangioleiomyomatosis. LCH is Langerhans histiocytosis, lymphangioleiomyomatosis. So these two diseases also cause pneumothorax. When we discuss pneumothorax, I'll tell you about these diseases. Coming to group 3, it is due to primary respiratory cause. How will a primary respiratory disease be responsible? Hypoxemia, pulmonary vasoconstriction, pulmonary hypertension. Group 4, due to chronic thromboembolic events in pulmonary circulation. Group 5, miscellaneous group or unclear mechanism such as sarcoidosis, sickle cell disease, Langerhans histiocytosis and lymphangioleiomyomatosis. Apart from this, there is another classification for pulmonary hypertension. It is hemodynamic classification for cardiac origin. Depending upon the cardiac origin, pulmonary hypertension is classified into two groups. Those without cardiac origin, non-cardiac pulmonary hypertension, those because of a cardiac disease, cardiac pulmonary hypertension. Now with the classification previously, which belongs to cardiac origin, generally it is group 2. Which are non-cardiac origin, it is group 1, group 3, group 4 and group 5. Actually we don't know the exact mechanism, so according to new classification we are not putting it in either. So non-cardiac generally group 1, group 3, group 4, cardiac group 2. Now what are the important features of cardiac? It is a pulmonary hypertension, so MPAP will be elevated more than 20 mmHg. Non-cardiac, here also MPAP will be elevated more than 20 mmHg. Then what is the difference? Because it is due to left heart disease, PCWP will be elevated. It will be elevated more than 15 mmHg. Here PCWP, because there is no left heart disease, it will be less than 15 mmHg. See students, in ARDS the reference value is 18. This was given by separate group of people. They have taken reference value as 15. So generally the reference value for significantly high pulmonary capillary wedge pressure is usually more than 15 to 18. Because this was given by other group of people, they have taken 15 as the reference value. Apart from this, there is apart from this classification, important here is, if you go to the anatomical level, there is an interesting feature. Consider this is the alveoli. You know that to the alveoli, where is the blood coming from? It is coming from the pulmonary artery. So this is the pulmonary artery, and your pulmonary artery at the level of alveoli give multiple branches called as capillaries. These are pulmonary capillaries. These capillaries, after gaseous exchange, they merge into a big vessel called as pulmonary vein. So they merge into a big vessel called as pulmonary vein. This pulmonary vein will join into the left atrium. This pulmonary vein will join into the left atrium. Now if you notice, anything happening before the capillaries, is called as a precapillary phenomena. Anything happening after the capillaries It is called a post-capillary phenomena. Now if you see in cardiac origin pulmonary hypertension, most of the pathophysiology is happening in the post-capillary region. Left atrial pressure increases, pulmonary venous pressure increases, then pulmonary capillary, then pulmonary arterial pressure. Because in cardiac origin, most of the pathophysiology is happening in the post-capillary region. Now if you observe here, students, in the cardiac group, the predominant pathophysiology is happening in the post-capillary region, left atrial involvement, pulmonary venous involvement. So that's why the cardiac group is also called as post-capillary pulmonary hypertension. So what you need to know is, because the predominant pathology in cardiac pulmonary hypertension is happening in the post-capillary region. So the cardiac pulmonary hypertension is also called as, so this is another name, post-capillary pulmonary hypertension. Whereas in the non-cardiac causes, group 1, group 3, group 4, there is no involvement of post-capillary region. So it is called as pre-capillary pulmonary hypertension. So the other name for non-cardiac pulmonary hypertension is pre-capillary pulmonary hypertension. What you need to know for your exam is, if they mention post-capillary pulmonary hypertension, they are asking about cardiac origin pulmonary hypertension group 2. If they mention pre-capillary pulmonary hypertension, they are asking about non-cardiac origin. It can be either group 1, group 3, group 4, and you should know the parameters. In cardiac origin, both MPAP, PCWP will be elevated. In non-cardiac origin, MPAP will be elevated, but PCWP can be less than 15 mm Hg. Then coming to the treatment, most important in management of pulmonary hypertension is treating the underlying disease. If it is a heart disease responsible, treat the heart disease, it will take care of pulmonary arterial pressures. If it is due to some lung disease, treat the lung disease, it will take care of pulmonary arterial pressures. Even after treating, if patient is not improving, now you should give drug therapy that can decrease pulmonary arterial pressure. First will be treat underlying cause. If patient not improving, what you should do next, students? You should start direct drug therapy. That can decrease pulmonary hypertension. Important, calcium channel blocker such as nifedipine. Previously it was used, now because of side effects, now not used routinely. Then what are the drugs routinely used in pulmonary hypertension? We have endothelin receptor antagonist, that is bosentan, ambrisentan. Then we also have PDE5 inhibitors. PDE5 inhibitors such as sildenafil, tadalafil. Apart from this, we also have prostacyclins such as iloprost. This iloprost is available as inhaled form. Then there is ipoprostinol. This is available as IV form. whereas majority of medications are tablets. Prostacyclins such as iloprost, epoprostenol exceptions, available as inhaled form, IV form. Then there is also prostacyclin agonist such as selexipag. This is available again as a tablet, selexipag. Then a new group, guanylyl cyclase stimulator, that is Riociguat. These are various drugs helpful in management of pulmonary hypertension. Then how do you prescribe these drugs? Write down drug regimen for pulmonary hypertension. Initially when the patient reaches to us, we nowadays start with combination of endothelin receptor antagonist with PDE5 inhibitor. ERA means endothelin receptor antagonist such as bosentan, along with that PDE5 inhibitor such as sildenafil. If patient is improving, we will continue the same treatment. If patient not improving, we add a third drug. We can add prostacyclin. Initially we can try with selexipag tablets, then we can go for iloprost or epoprostenol. But in the question, if they mention drug of choice in emergency situation, whenever there is an emergency situation due to pulmonary hypertension, in emergencies, which will work better, tablet or injection? Injection. What is available in injectable form? Epoprostenol. Drug of choice in emergency situation will be epoprostenol. Drug of choice in emergency situation will be epoprostenol. This will be the drug regimen, and these are the various drugs that we are using in management of pulmonary hypertension. Initially it is combination of ERA plus PDE5 inhibitor. If patient is not improving, we add prostacyclin. Drug of choice in emergency situation, it will be intravenous epoprostenol.